Hi guys. So lecture on spinal trauma. So we'll just start off with some anatomy. So you've got 33 bones in your spine, but only 24 of them can actually move. The bottom ones down in the sacrum and the coccyx are fused. And the ones that can move, in green on this slide, is your cervical bones, and you have 7 there, so C1 to C7. These are the most mobile bones in your spine and predominantly where a lot of injuries will occur. The pinky maroon colour here are your thoracic vertebrae, and you have 12 of those. Again, T1 to T12. Your lumbar vertebrae, you have 5, so L1 to L5. And when we're talking about traumatic spinal injuries, there's a couple of different types as per textbook. So you have hyperextension injuries where your head is flexed right back. This is sort of like a whiplash injury, and that can crush or damage the rear aspect of your vertebrae or your spinal cord. Moving down with hyperflexion, which is the exact opposite. So your head being excessively forward, which can damage the anterior aspect, so the front side of either your cord or your vertebral bones. You can have compression injuries. In this image, for example, diving into a pool, hitting your head on the bottom, where your entire spine is crushed. Again, will cause both bone damage and or cord damage. You can have excessive rotation. If your spine has a fair bit of movement, it's designed to be able to move laterally, but excessive rotation will start to initially damage and degrade the discs between the spine, between the vertebrae, and then start to actually tear the cord itself. Lateral stress, different to rotation in that it's not a twisting, it's just the head being excessively turned to either side. So again, you'll end up with those crush fractures on whatever side it was excessively turned towards. And then distraction injuries that you get from hanging, whether the vertebrae and the cord are stretched and pulled apart. So there is a difference between vertebral injury and spinal cord injury, although they often do occur together. So vertebral fractures, the way that you'll be able to tell the difference there is that they're painful. As with any bony fracture, they're painful. You can have a broken back and still walk again. If there's no impingement or damage to the spinal cord within the vertebrae. So it's entirely possible for the vertebrae to fracture. So someone has terrible, pain in their neck or thoracic back following, say, a car crash or some other traumatic injury, but full movement sensation in their arms, legs, no neurological signs, means their cord is uninjured. So you need to differentiate those. You can obviously tell when someone has some spinal cord injury because there will be some sort of neurological signs. There'll be a loss of sensation or altered sensation, and potentially a loss of motor function or weakness. Again, just more distinctions, traumatic and non-traumatic injury. A very common call if an ambulance is back pain, but this is non-traumatic back pain. So someone who has, slip discs or nerve damage or ongoing muscular injuries, even osteoarthritis, can have terrible, severe back pain, but we don't need to manage those the same way we manage traumatic back pain. The focus there is just on pain relief, essentially, and getting them up to hospital for scans and further assessment. So when we talk about back injuries in this lecture, we're talking about traumatic back injuries, not these long-term chronic medical ones. Now, spinal cord injury can be complete or incomplete. Complete is relatively straightforward. There is no motor sensation, no motor function, and no sensation below the point of injury. And depending on how high it is, they'll either be paraplegic, where they've lost the motor and sensory function in their legs but still have their arms, or quadriplegic, sometimes called tetraplegic, where above the injuries occurred higher up and they've lost both their arms and legs. Now, you can also have incomplete spinal cord injuries where there is damage to the spinal cord, but it hasn't completely severed the neuronal activity going up and down. And there are 3 textbook definitions. The first is central cord syndrome, where the center of the cord is damaged, typically by a hyperextension injury. And you can have a suspicion of this in the field because the arms will lose more function than the lower body. So someone may have limited motor or sensory function in their arms, but they can still walk, they can still feel everything on their legs. Another type is called anterior cord syndrome. This is actually normally a medical problem where a blood clot will cause the anterior aspect of the cord to become ischemic, but it can be traumatic as well, which is why we're covering it. For whatever the cause, blood supply is lost to that anterior section of the cord. And again, you can have a suspicion of this because the patient will still be able to feel vibration and they will still have a sense of where their limbs are, even if they've lost sensory or motor function to them. And that is called proprioception. And the final one is called final incomplete spinal cord injury, is called Brown-Séquard syndrome. And this is always traumatic, usually penetrating trauma like a bullet or stab wound. And this is where the cord down the length of it has been split. This is an easy one to pick because the patient will have preserved motor function on one side of the body and preserved sensory function on the other side of the body. So they'll have one arm or leg that they can move but not feel, and then one that they can feel but not move. And that's because if the cord's been split in half, those ipsilateral components aren't able to communicate with each other anymore. Now going back to vertebral injury, so separate to spinal cord injury, there are two types of injuries that can occur with your vertebrae. You can either have compression fractures, which is the image here on the left, or you can have burst fractures, which is the image on the right. And as you can see, burst fractures are just more serious. So compression is where part of the vertebrae has been, fractured, damaged, but the integrity of the spine is still relatively intact. Whereas burst is when it's actually left its normal anatomical designation, and as this image shows, very commonly impinges in on the spinal cord itself, as well as protruding out through the back. Vertebral injury, as I said before, separate to spinal cord injury, but they are frequently associated. You can differentiate them because a vertebral injury, as with any fracture, is extremely painful. And the muscles around, say if I were to have a fracture in my neck, the muscles would spasm. So the patient will typically be very rigid, lying down, won't want you to move them, complaining of terrible pain and muscle spasming at the site of injury. And you can check for your neurological signs separate to that. They may have terrible pain, terrible spasming, but they can feel you touching their toes, fingers, wiggle them all, and they've got to have that preserved neurological function. Now, there's a thing called neurogenic shock, which can happen in most commonly complete spinal injury. And the pathophysiology behind it is that the vagus nerve is the only nerve in your body that doesn't run down through your spine. So if you have a total spinal injury, the function of your vagus nerve is preserved throughout your body. Now, normally your parasympathetic and your sympathetic systems have a push-pull dynamic and they work in unison with each other. But of course, if all your sympathetic tone, which runs up and down your spinal cord, has been lost in a complete spinal injury, now the parasympathetic system, which is innervated by the vagus nerve, has total control of your body. And it can lead to a large-scale set of parasympathetic symptoms, such as vasodilation, bradycardia, and this will present with a very hypotensive patient, which you can differentiate from a hypovolemic hypotensive patient, because these patients aren't actually losing their volume. They're in essentially a form of distributive shock below the point of injury. So they'll be hypotensive, but they'll be warm. They won't be, pale and clammy and sweaty like you see in people who are bleeding. Because they are so vasodilated, they will feel warm to touch, but they will be radiating a lot of heat and may actually become cool over time. Their core body temperature will drop. Bradycardia may or may not be present depending on exactly how high the level of spinal injury is. Now, the management of spinal injury depends on the presentation. Historically, there is a growing consensus that these injuries have been overmanaged, where anyone who had even the tiniest suspicion of a spinal injury or even a mechanism that could potentially be associated with a spinal injury had extended on scene time, very rigid full bodily immobilization. It was very uncomfortable for the patient. It took a long time. And at best is probably of limited value. At worst, there's some evidence that it may actually worsen these patients' outcome. So there's been, in Australia at least, a significant pullback on the management. So a lot of it relies on your clinical judgment and you having a good assessment. So you need to decide whether you think you're looking at a vertebral fracture or a neurological injury, whether there's actually damage to the spinal cord. If a person is complaining of back or neck pain, so they've been in a car crash, but they have completely preserved neurology, you're probably just looking at a vertebral fracture. Now, if you were to very poorly manage that and really reef them around and cause a really enormous amount of movement, there is a theoretical chance that you could cause a spinal cord injury. But even any attempt to just reduce their movement and minimize their movement without resorting to full bodily immobilization is appropriate. So we've moved to soft collars now, away from rigid collars. They were very problematic. So someone who just, for example, has cervical spine pain, all they need is soft collar and either supine or semi-recumbent positioning. If they just want to sit at a slight angle and keep their head still, which the collar will remind them to do anyway, there is no need for rigid full bodily immobilization on a spine board. You've got to remember, if these people have fractures, they're not going to want to move their heads anyway. They're not going to need any encouragement to keep their head still. Someone who's able to reef their head around and look at you almost certainly is not going to have a fracture or spinal cord injury. Now, if you have thoracic, lumbar, or sacral pain, so the lower aspects of the spine, again, soft collar. And these are the ones where we do use supine positioning and immobilization to a long board. What we don't do is put people on a flat spine board and strap them in super tight so they can't move. This is just having someone on a scoop stretcher with a collar on, maybe with a towel on either side of their head, and just let them manage their own body. If they need to shift and move a little bit to relieve pain, that's actually to their benefit. Again, they're not going to, if they've got severe burst fractures to their thoracic spine, they're not going to be moving a great deal anyway. And same if you have genuine neurological signs, that's your most serious one. So someone who's genuinely lost motor or sensory function to their arms or legs, you take that quite seriously. Do your best to minimize movement. But again, all we're looking at is a soft collar, maybe some towels, stop them moving their heads, and a scoop stretcher. Now, one of the important things you can do is have a neutral head position. And put this graphic in just to show the difference between different ages. So infants, they have big heads. If you just lay a baby flat on its back, its spine will actually not be straight. Because it has that large occipital lobe, it actually raises the head up and the spine will be curved a little. So if you can, what you want to do is put a towel or something under the shoulders, and it lifts the shoulders up in line with the head so that the C-spine, the cervical spine, is straight. Now, older children are anatomically perfect to just lay on their back. They're nicely balanced. Adults tend to have, relatively small heads compared to their body. So you do the opposite of what you would do for a child. You just raise their head up a little bit on a towel, and it will keep their C-spine nice and straight, in a straight line down their whole body. Now, the management, apart from the extrication that I went over before, it's very important to document this stuff properly. So document exactly where the loss of sensation or loss of function occurs, because that will help the treating doctors, in the ICU or the neurologist down the track, to determine is the treatment helping or hindering? Is the person getting better or worse? For example, the example I've given here is someone, if they can't feel their pinky, but they can feel the rest of their hand, that correlates to one of the dermatomes in the spine. So if they can look at your paperwork 2 or 3 days down the track and see that now the patient, can't feel their hand at all, or has full function back to the hand, that can really give them an idea of how the patient's trending. Apart from that, we manage neurological signs, so someone who has reduced motor or sensory function, as a similar to a head injury. And we want to make sure that we avoid the same things that we have talked about avoiding in head injury, which is hypoxia and hypotension, because your spinal cord is part of your central nervous system, just like your head is. So we treat them the same, the CNS treatment. And that's it. Thank you.